Hello, it's my distinct pleasure to introduce our next speaker, Dr. Carolyn Becker. She is one of the course directors for the IREM course, and she's a master clinician educator from the Division of Endocrinology, Diabetes, and Hypertension at Brigham and Women's Hospital, and an associate professor of medicine at Harvard Medical School. She'll be speaking with us today about osteoporosis and metabolic bone diseases. Thank you so much, Dr. Becker.
Thank you very much, Dr. Rexroad, and thanks to all of you for hanging around for the last talk today. And these are my disclosures. I write 2 chapters for Up to Date. And because this is the last talk of the day, I decided to make it a case-based lecture, so hopefully we can all stay awake. So case 1, this is a 50-year-old postmenopausal woman who comes to see you for the first time. She is thin, she smokes 1 pack per day, she drinks 3 glasses of wine daily, and notes that her mother fractured a hip at age 70. However, she herself has never fractured. You do a screening DEXA because she's thin, she smokes, she's got risk factors, and that shows a T-score of -1.8, -2, and -2.2 at the spine, femoral neck, and total hip respectively. So she has osteopenia. So for the first ARS here, in addition to counseling this patient about lifestyle changes, what else would you do? A, check a marker of bone resorption. B, begin an oral bisphosphonate. C, perform a FRAX calculation. Or D, prescribe calcium and vitamin D. Okay, I think we'll move ahead. So most of you, 70%, are picking the correct answer, which is perform a FRAX, and some of you are picking prescribed calcium and vitamin D and a few other things. So the correct answer here is to perform a FRAX calculation. And we'll go over why. So a baseline marker of bone resorption, which we'll talk about a bit later, is not required for making treatment decisions. It is nice for monitoring whether a patient is taking their medication and getting a response from the medication. Oral bisphosphonate is appropriate if she meets criteria for treatment, but you don't know that yet. And calcium and vitamin D are very useful as part of a comprehensive fracture reduction strategy, but not as any standalone therapy unless this is someone you know is deficient in calcium and vitamin D. And you don't know any of that yet, except from asking her about her diet. So the FRAX calculation should be done. It looks like this. Hopefully most of you are familiar with this. And here's a patient similar to our own, a 50-year-old female. She has never fractured. Her parent fractured a hip. She's a smoker. She's also taking steroids, which our patient was not, but she also drinks a fair amount. And when you calculate after putting in her T-score at the femoral neck, it comes out that this patient has an increased risk of hip fracture above the treatment threshold, which we'll go over. So in 2019, the Endocrine Society came out with guidelines. Whom should you treat for osteoporosis? And basically there are 3 categories. Number 1, any postmenopausal woman who comes in with a fragility fracture, a fall from standing height, a very minor fall, or especially someone who comes in with a vertebral or hip fracture. Absolutely, these patients should be treated irrespective of bone density. Number 2, any postmenopausal woman who has T-scores of less than or equal to -2.5 at any site on a DEXA. And number 3, like our patient, someone who doesn't meet criteria by fracture or DEXA criteria, but has osteopenia with a high 10-year probability of major osteoporotic fracture over 20% or a hip fracture of 3% or more on the FRAX score. And I would say that if you have a patient with primary hyperpara, you want to always get the 1/3 distal radius on the DEXA as an extra site because that's mostly affected by primary hyperpara. And I'd also say that these criteria for treatment are different in patients with long-term glucocorticoid exposure. Other considerations from the Endocrine Society are that someone with a recent fracture within the last 2 years is at much higher risk for an imminent fracture than is someone who comes in and says, I fractured my wrist 15 years ago or 10 years ago. The person who comes in with a recent fracture, you really want to be aggressive. And in addition to vertebral and hip fracture, the data have shown that recent wrist or humeral fractures also predict a high risk for imminent fractures. Now, I want to go over briefly pharmacologic therapies for osteoporosis. We, again, have 2 buckets. The major bucket is the large group of anti-resorptives. These stop the breakdown of bone. That includes a SERM, raloxifene, large number of bisphosphonates, denosumab or Prolia, calcitonin nasal spray is barely used, and estrogen progestin, which we heard about in earlier talks. And another category, the bone building agents, anabolic. This is a growing list. We had one therapy since 2002, and in the last few years, we've had 2 more therapies. Due to time and this being a broad audience, I'm going to not talk about anabolic therapies other than to say these are generally reserved for people with severe osteoporosis. So our patient would be treated after, we'll see what we do next. So this is case 2. This is a 65-year-old woman who has osteoporosis on a screening DEXA with her lowest T-score minus 2.8 at the spine. You do a complete laboratory evaluation and include a fasting 8 a.m. serum C-telopeptide or CTX, of which comes back 550 picograms per ml. The reference range for women who are postmenopausal is 35 to 836, so she's in the normal range. All her other labs are normal. She feels fine. She's never fractured. She is very hesitant to take medication, but after you discuss her risk with a low T-score, she reluctantly agrees to try a weekly oral bisphosphonate. 6 months later, after you start the bisphosphonate, you repeat her fasting CTX, and it comes back 525 picograms per ml. What is the most likely cause of this result? A, is it poor compliance with treatment? B, inadequate calcium and vitamin D? C, gastrointestinal malabsorption? Or D, failure to diagnose and treat an underlying secondary cause of osteoporosis? Give you a few minutes, a few seconds. Okay, well, this is a very smart group. The majority of you, 77%, got the correct answer, poor compliance with treatment. And indeed, that is the correct answer. We'll go over the others. Compliance, which means both adherence and persistence with oral bisphosphonates, is very poor. Only 35 to 50% of patients persist in taking an oral bisphosphonate for over 6 months. So that is far and away the first thing you should ask about and think about when you see what looks like a non-response. Adequate calcium D should always be assessed, and that could be the correct answer. GI malabsorption of oral bisphosphonate may reflect the fact that they're taking the bisphosphonate with food or with other pills or with calcium. Or in some cases I've seen the patient actually takes the bisphosphonate correctly, but does not absorb it well. Occult celiac disease may be happening, or another GI disorder can be responsible. So this can also be the case, but compliance is number one. If you really ask the patient how often is she missing doses, how does she take the weekly oral bisphosphonate, and really the compliance seems to be good, then absolutely you should do an additional workup for secondary causes. So the teaching points about checking markers, a fasting serum CTX should decrease by about 50% from baseline after 6 months of taking a potent oral bisphosphonate therapy. Compliance with an oral bisphosphonate, which is associated with this 50% decline in CTX, correlates well with improvements in bone density. And the ideal range of a fasting serum CTX in a patient on chronic potent anti-resorptive therapy is not in the postmenopausal range, but should be in the lower half of the premenopausal range, where we think the degree of bone turnover is ideal in the premenopausal range. So if this is the normal premenopausal range of bone turnover, a postmenopausal woman on a potent bisphosphonate should be at around 100 to 200 on her CTX after she's been on this for 6 months. Okay, case 3. This is a 65-year-old postmenopausal woman with osteoporosis who has been taking an oral bisphosphonate now for 5 years. She has done great. Her BMD has improved significantly at all sites. She has never fractured. She has a healthy lifestyle, exercises, gets adequate calcium and D, and has no serious comorbidities. Her current DEXA shows T-scores of minus 1.5 at the lumbar spine, minus 2.2 at the femoral neck, and minus 1.8 at the total hip, respectively. So my question now is, what would you recommend for this 65-year-old woman? A, would you check a fasting serum CTX to assess her compliance? B, continue the bisphosphonate until all T-scores are above minus 2. C, stop the bisphosphonate and switch to raloxifene. Or D, stop the bisphosphonate and monitor. Okay, well, this, I think, maybe you've heard these lectures before, but you are doing great. This is a really good group. 84% of you got the right answer. This is time to stop the bisphosphonate and monitor. So serum CTX is not needed here. Her bone density results and lack of fractures, not the CTX, are used to assess the efficacy of osteoporosis treatment, not the compliance. You can assume she's compliant. She's done very well with 5 years. The treat to target goal of osteoporosis therapy is to increase the T-scores to above minus 2.5 at all sites, which she has achieved. And raloxifene is a weak anti-resorptive without anti-fracture benefit at non-vertebral sites. So there'd be no reason to put her on that after stopping the bisphosphonate. So this is a patient for whom a bisphosphonate holiday is warranted. So let's talk about bisphosphonate holidays. The elephants in the room are the side effects of long-term bisphosphonate use, including osteonecrosis of the jaw, a horrible condition seen here, as well as atypical femur fractures. Here's a patient with bilateral bisphosphonate-associated femur fractures, atypical fractures. And because of these limitations, these terrible adverse side effects that come with prolonged bisphosphonate exposure, we've wrestled with how we can give patients the benefits of bisphosphonates without the risks. So here is what the experts have come to. After 3 years of intravenous zoledronate or reclass, or 5 years of oral bisphosphonates, you should reassess the patient's fracture risk. If the patient remains at high risk for fractures, they just had a fracture, they still have low T-scores, especially at the hip, they fall a lot, it's a frail elderly person, or they're on a high-risk medication such as high-dose glucocorticoids, aromatase inhibitors, et cetera, consider continuing the bisphosphonate for another 3 to 5 years or switch them to anabolic therapy. These are not the people for whom a drug holiday is warranted. Patients at low to moderate risk, on the other hand, can safely go on a bisphosphonate holiday. And again, from the Endocrine Society guidelines, I've made this table. Low and moderate risk patients are ones who have never had a hip or spine fracture. Their bone density is above the osteoporotic range. And if for some reason their bone density is not obtainable or they've got artifact, you can use the FRAX score here, and you want them to have low FRAX scores, not high FRAX scores. On the other hand, a patient who has had a hip or spine fracture still has osteoporosis, and if you do the FRAX score, they've still got a high FRAX score, or they've had multiple spine fractures, et cetera. These are the high and very high risk patients for whom there is no holiday. So you do not want to give them a drug holiday. You want to maybe switch them to something else, but not stop the medication. So how do you manage a bisphosphonate holiday? Think of it as a temporary discontinuation of bisphosphonate therapy for up to 5 years in some patients. And once you've started the holiday, reassess the fracture risk at 2 to 4 year intervals. You can consider restarting the bisphosphonate if you see a marked decline in bone density or the patient fractures or their clinical status changes. They come into you and they've had a stroke, so now they're relatively immobilized. They've now developed temporal arteritis and they've been put on high-dose steroids. They have breast cancer and they're on an aromatase inhibitor. All of these things change the calculation. And I would always see my patients back once a year for a clinical assessment. Have they fallen? Have they fractured? What's changed in their health? Let's move on to case 4. This is an 80-year-old woman with severe osteoporosis, multiple fractures, and CKD with an estimated GFR of 28 mils per minute, who comes in to see you. She's been on denosumab 60 milligrams sub-Q every 6 months for the past 5 years. She has done fabulously well. She's gained 8 to 20% on the bone density at all sites. She's had no more fractures. She's really done well on this. Her lowest T-score remains in the osteoporotic range at the femoral neck, minus 2.7, but she hears about drug holidays and asks if she can have a drug holiday for 1 or 2 years. So what do you recommend for this patient? A, continue the denosumab indefinitely. B, stop the denosumab for a 2 to 3 year holiday. C, switch from denosumab to annual infusions of zoledronic acid or zoledronate. Or D, lower the dose of denosumab to 60 milligrams sub-Q once a year. See if I can stump you. Okay. All right. This is, I think, a superlative group of attendees. 72% of you are getting the right answer, which is to continue the denosumab indefinitely. So let's go through these answers. Patients at highest risk for fractures should not stop therapy. And we've already gone over this. And this woman is 80. She's had multiple fractures. She still has osteoporosis. She needs to be on something. But denosumab should never be stopped for a holiday because there's a rebound in bone resorption markers, a rapid loss of bone density at all sites, and even in some cases, multiple spontaneous vertebral fractures. Here's a picture, an MRI of the spine of a woman on denosumab doing well, who then stopped the drug. And within a short period of time, she sustained something like 5 or 6 spontaneous vertebral fractures. There are now multiple reports of this rapid bone loss. And in a small subgroup of patients, these spontaneous, terrible, painful vertebral fractures. This shows what happens with bone density. This is a group of patients who took denosumab for 10 years. They gained 8% at the total hip and bone density. At year 10, the drug was stopped. And this is what happened to bone density within 1 year. It actually dropped below baseline. That's how rapid the loss can be. So why not give zoledronic acid? We are giving this 7 to 8 months after denosumab for people who cannot take the denosumab. Let's say they have an allergy or a side effect, and this has been shown to blunt this rapid bone loss, though it doesn't totally stop it. However, remember this patient has CKD. Zoledronate and alendronate are contraindicated when the GFR is less than 35 mils per minute, and even risedronate is contraindicated. That's Actonel when the GFR is less than 30. So this lady's GFR is 28. These bisphosphonates are contraindicated. So the correct answer, continue her denosumab indefinitely. Case 5. 38-year-old woman undergoes Roux-en-Y gastric bypass surgery for morbid obesity. Over the next year, she loses 120 pounds, which is great, but she complains of progressive proximal muscle weakness and diffuse bone pain. She recently sustained spontaneous metatarsal and rib fractures, and on exam, she has a waddling gait and is tender over her hips, pelvis, and extremities. She has normal electrolytes and creatinine. Her calcium corrected for albumin is a little bit low. Her phos is low. Her alk-phos is high. Her intact PTH is high. And her DEXA, because she's a young woman, we use Z, not T scores. Her Z scores show low bone density at the spine, femoral neck, and total hip, respectively. So what key test should you order next? A 125 dihydroxy vitamin D level, B, a 25 hydroxy vitamin D level, C, a 24-hour urine calcium excretion, or D, a 24-hour urine phosphate excretion. A little tougher one. Looks like the 2 vitamin Ds are duking it out here. Okay, for the sake of time, I'm going to stop now, And it looks like, boy, it's really neck and neck, hard to say. So what key test should you order? The correct answer here is a 25 hydroxy vitamin D level. So let's go through this. And it turned out her 25D came back undetectable, and treatment is to put her on often high doses of calcium and vitamin D. So what's going on with this patient? Why isn't the 125 dihydroxy vitamin D right, even though that is the activated vitamin D? And the reason is that in patients with profound vitamin D deficiency, which this patient has, 125 dihydroxy D levels may be high, normal, or low. And that's because even a little bit of vitamin D substrate may get rapidly converted to 125. Renal function can affect it, and PTH can drive this conversion of 25 to 125. So that is not a good measure of vitamin D stores. The serum 25D is the most useful marker of vitamin D status and can be profoundly low following malabsorptive bariatric surgery like the Roux-en-Y. This results in osteomalacia, which is undermineralized or unmineralized bone matrix, and it's from deficits of calcium, phos, and/or vitamin D. These patients present with diffuse bone pain, muscle weakness, gait disturbance, and atraumatic fractures. And this is a very serious complication of malabsorptive bariatric surgery. 24-hour urine calcium excretion will be low in the setting of calcium malabsorption, which is very common after Roux-en-Y. She had a secondary hyperpara. So this is not going to help you make the diagnosis. You can predict it from her labs. The 24-hour urine phosphate excretion is very useful in primary hypophosphatemic disorders of bone. But in this case, the hypophosphatemia is secondary to the vitamin D deficiency and the high PTH, which is phosphaturic. Let's move on to case 6. This is a 64-year-old previously healthy woman who sustained severe back pain while working out at the gym. She takes no medications. She has never fractured before. She does note fatigue and bone pain for several months that she attributes to, quote, normal aging. On exam, she's got marked tenderness at L1 and L5. And her DEXA reveals T-score of -3. That's her lowest T-score at the spine. And I'm going to show you an MRI of her lumbar spine. And here you can see L1 and L5. The vertebrae are severely compressed. So that the DEXA is based on 2, 3, and 4. So in addition to routine labs, what would you order next? A total body radionuclide bone scan. B, serum and urine protein electrophoresis. C, a 24-hour urine-free cortisol. Or D, vertebroplasty with biopsies of L1 and L5. Okay, I think the answer would be between B and D. So let's move on. The correct answer is B, to get a serum and urine protein electrophoresis is the next test. So this patient on screening had a hematocrit of 30, creatinine of 2, calcium of 11.5, and a PTH less than 10. This was a real patient who was sent to me for osteoporosis. And here is her SPEP showing multiple myeloma with a gamma spike. So a total body radionuclide bone scan can be useful in certain conditions, such as pages of bone, metastatic breast and prostate cancer, but would not be the best step here, and in fact would light up at the fractures, but would not be taken up by the myeloma cells. Serum and protein electrophoresis to rule out myeloma should always be done in a setting of severe vertebral osteoporosis and/or fractures. 24-hour urine-free cortisol to look for Cushing's would be a good thing to do in a patient who had any stigmata like striae or supraclavicular fat pads, a round plethoric face, central obesity, who presented with in particular vertebral osteoporosis or fractures, but she did not have this, and that was not the correct answer. Vertebroplasty with biopsy is invasive and not indicated prior to a more complete laboratory evaluation. If the laboratory evaluation was negative and you had no other reason for these vertebral fractures, these sudden spontaneous fractures, this could be considered for a diagnostic purpose. We usually don't do vertebroplasty for pain until at least 6 or 8 weeks have gone by. So just to remember, there is a differential diagnosis of disorders associated with osteoporosis and fractures. There's a long list of other disorders that are shown here, both benign and malignant disorders, inflammatory disorders, and even diabetes, both type 1 and type 2. The workup for secondary causes of low bone mass and fractures, generally everything on this green slide, I would consider a minimum workup. And then these other things, PTH, SPEP, UPEP, ferritin, celiac, cortisol, can be done if the situation and the clinical suspicion is there. But I consider these to be the basic workup for anyone with significantly low bone mass and/or fractures. So with that, I'm going to give my take-home points. The clinical evaluation of metabolic bone disease includes a thorough history and physical exam. DEXA, FRAX, laboratory and other testing is indicated. Osteoporosis therapy may need to change if there is a poor response, poor compliance, or if the patient fears, preferences, or health issues change. The duration of therapy depends upon both the risk profile of the patient as well as the biologic characteristics of the therapy. You don't want to stop denosumab, as I showed. And since many patients require lifelong therapy, you need to know the adverse effects of continuing versus the consequences of stopping any given osteoporosis therapy. Be aware of the differential diagnosis of fractures and low bone density. Not all fractures are from osteoporosis. Think about osteomalacia, think about malignancies. There is a differential. And I've given you some references here, and I really appreciate your attention. And I think I'm actually finishing on time, so we can maybe take some questions. Thank you so much for your attention.
Thank you so much, Dr. Becker, for those engaging cases to help us really solidify our knowledge of osteoporosis. A few quick questions. The first is on a very practical note. Do you have a specific recommendation about calcium for supplementation? And what do you tell your patients as we're thinking about calcium and these other medications?
Yes, that's a good question, comes up a lot. As a general rule, the general population does not need calcium supplementation. That has not been proven to be a good public health measure. However, patients with osteoporosis, any kind of malabsorption, young women in their prime, in their teenage years who are building bone, and anyone you're treating for osteoporosis or for fractures should have adequate calcium. Most of that is we like to get from food, from dietary calcium, Anything that can't be obtained through diet should be obtained through supplements for a total of anywhere from 800 to 1,200 milligrams per day of calcium. Vitamin D should be checked. If the 25D is not up to about 30 nanograms per ml, vitamin D should also be added to the calcium regimen.
Thank you. There was a question about whether any one bisphosphonate is better than others, or how to decide, as well as whether we should be routinely following the CTX when patients are started on bisphosphonates.
Great. I will tell you which bisphosphonate is the least effective, and that is abandronate. Abandronate is Boniva, and that does not protect against non-vertebral or hip fractures. So I really think I would take that off of my list of treatments. In terms of risedronate, Actonel, or alendronate, Fosamax, both of them reduce hip, vertebral, and non-vertebral fractures significantly. Zoledronate, the IV, also does. And so any of those are good. The costs are different. The oral drugs are the least expensive. But if you think someone may not be compliant or is hesitant to take the oral medication, or you worry about their absorption of the drug, maybe they had some GI issues and these are poorly absorbed drugs orally, that's someone where I think a CTX would be very helpful, because you don't want to waste a year or two treating someone who isn't absorbing the drug or isn't taking the drug properly. So if you're giving an IV bisphosphonate, you don't need to check a CTX. But if the patient is taking the drug at home orally and you want to check for compliance or absorption, a CTX before you start and about 6 months later can be very reassuring, or tell you got to change therapy.
That's really helpful. Thank you so very much.
My pleasure.